JP. So welcome. Thank you for being here with us. We've known each other for so many years. I started Hopkins in 2005. JP had finished his fellowship, joined the faculty a year prior, working and rise to the ranks of full professor over the next few years. You know, you can see his training. You can actually see my puppy right here, Rocky, who's getting excited of me just talking about JP Wolinsky. So I apologize for that, you know, but he may come in and want to join JP as well. Extraordinarily gifted. You can see actually his accomplishment from assistant to full professor, Department of Neurosurgery, and then moved to Northwestern in 2017 to become the director of the spinal oncology program, of also the fellowship program, professor of orthopedic surgery and neurosurgery, vice chair of the department. I mean, that's a tremendous accomplishment. These are some of his publications, tons of them. You know, you're about to see the H index that our team put together right here. He's got an H index of 44. You know, just as a reference, most of the professors around the United States for neurosurgery, their H index is one of the highest in surgery, but it's in the average of about 24 to 26. He's already doubled that at such a very, very young career and already so many amazing accomplishments. These are some of his covers of different journals. You know, we had so many of them. And I asked just the fellows just to put a few of them, just to illustrate some of his creativity, some of his originality, some of his innovation. And we're going to be hearing about this right here. At a personal level, you know, I think that as I hear him talk about innovation in spine surgery, the use of robotics and stuff like that, I asked him to give a talk that is visionary, you know, potentially even controversial, ask him probing to motivate people to think about the field. I'm going to go ahead and start sharing right here, JP, so we can see your face. I think that at a personal level, you have been an extraordinary friend. I learned so much from you when I was at Johns Hopkins, watching you operate, watching you interact with our colleagues, being in faculty meetings every Wednesday night with you until very late, and spending time together with you at different meetings, and seeing you last week at the CNS and all the things that you continue to accomplish. It just blows my mind. It just makes me very proud of the work that you're doing, and very proud of the fact that I can call upon you for anything that we need, you know, in regards to our innovation as well. So welcome, JP. We're delighted to have you here. Thank you for being here with us. And I know that you're going to be meeting some people after this. And thank you for putting and dedicating your morning. I know that you have a time zone difference and you're still here with us very early in the morning. So welcome, please take it away.
Thank you, Alfredo. Thank you for that wonderful introduction. It's great seeing you again, even though we saw each other just last week. You know, Alfredo and I go back way back when. Those pictures of seeing you running on the beach are great, because when I knew Alfredo was pre-running, and then he got into running, and it's been a wonderful change for him. I stopped running because I'm too old for that. So now let me just make sure I can figure out how to share my screen. Let's see. Alfredo, I think I might have your background somehow, since I'm not a.
Let's see, Gaetano, what did I, maybe we need to give him the ability to share. He may not be seeing the green button at the bottom.
So you should be able to share the screen already. If you click on the Zoom app, at the bottom, there should be a green button.
See.
Yeah, there you go.
You go.
You can see your screen. Yeah.
Ah, good. Okay. All right. Can you see me?
Yes, it's
presentation we see
mode.
You in the screen. Perfect. Beautiful.
All right. So this talk, I'm going to talk about innovation. I know we'll talk a little bit about robotics and spine surgery, and but I just really wanted to talk about innovation in general. This is Chicago. Looks a lot like Florida. We have a beautiful beach. The water is different. It has waves, but it's fresh water. So I guess you can go swimming during the day and then go back to work without having to take a shower, but I haven't done that. The other difference is that in a few months, this will be, instead of blue, it'll be ice and cold, which I don't think you guys will ever have, hopefully. Anyway, so let me get into this. So what is innovation? I mean, is innovation, you know, having a beautiful lab tower, or having a, you know, wonderful 3D printers or simulators? I think those are all tools for innovation. They're not innovation in themselves, right? So if you look at Webster's definition of innovation, which I was actually surprised when I looked it up that there wasn't actually much. Usually a definition has lots of words behind it, but this one really was pretty simple. It's just a new idea, a new method, or a new device. And so when I think about innovation, I think about what do you really need to innovate? I think all of us actually have these tools right in front of us. You don't need necessarily a fancy lab for them. You just really need to look at something right in front of you, maybe change the angle that you're looking at it, and just change its application, and then change what you're doing. Now, not everything you think about will be innovative, or maybe it will be innovative, but it might not be safe. But so these are the things that you need to think about as you go through this, right? And so I'm going to go through two different sort of case scenarios at either ends of the spine that I think mean a lot to me. And so my big focus is spinal oncology and craniocervical junction. So I'll talk about some approaches to the skull base and also to sacral tumors. So one of the types of cases that I see quite a bit are craniocervical junction issues, particularly with cranial settling and basilar vagination. And in this patient, you can see that the odontoid is just way up into the skull base and pushing on the brainstem. And this patient presented with brainstem compression type symptoms, similar to your earlier case with the aneurysm, although this is not an acute problem, although that giant aneurysm wasn't an acute problem, it's slowly evolving over time. But so when we think about these types of cases, there's really different ways that we approach these things. And I put them into two different categories of how we approach a case like this. Are we going to approach them by decompressing them indirectly, meaning reduce some traction, pulling the head essentially away from the cervical spine, or pulling the cervical spine out of the head? Or do we need to do a direct decompression? And for somebody like this, where you have about 2.5 centimeters of cranial settling, I propose really doing direct decompression, because I don't think it's going to move enough. And when we think about direct decompression, you need to think about the pathology you're treating. If you're treating an intradural pathology, then you really want to avoid sort of transoral, transnasal, or transmandibular type of approaches. If you're doing extradural pathology like this cranial settling cases, then direct decompression is a great option for them. And so when you think about the anatomy in this area, this is, if the front of the face was removed and you're looking at the front of the cervical spine through the back of the face, essentially. So I don't know how to get my pointer to work on this, so you can see, but I'll just describe, what you're going to first look at. You'll see the longest well, the first thing you're going to look at is the posterior pharynx, then you'll see the longest capitis muscles covering over the clivus and the anterior aspect of C1. Behind C1, you'll see the odontoid, and behind that is the dura, followed by, the basilar artery. Now, traditional approaches to this would be the transoral approach. And really where that brings you is it brings you probably to the base of C2, but really to the tip of the odontoid in its natural position. If you try to look higher, if you have much more cranial settling, the transoral approach really is not going to get you up. The mandible is going to get in your way. And if we want to get up higher, we need to do a transmandibular type of approach. Fantastic operation from a surgeon's perspective. Patients don't seem to like it as much, but if it achieves their goal, they're very happy. And how we do this, we split the jaw. The old way of doing it before plates and screws were available is we would make a step-like cut in the mandible so that we could reapproximate these things and wire them together. Now with plating, we can make a nice linear cut and try to save these alveolar nerves. When you go through there's different ways to go back to the posterior pharynx, but a circumglossal approach spares cutting the tongue, and if you can also protect then the lingual nerve and the mandibular nerve in this area. So this is the view that you'd get after exposing this area, and you can see from the top of the clivus all the way down the cervical spine. So it can give you a huge range of exposure, but remember, it's still a narrow corridor. And these wonderful illustrations from Ian Sook, show it like you can see everything and get in there very well, but in reality, it's a little bit tighter. So how is somebody positioned for this supine operation? I usually put them in a halo just to keep their neck stable after this whole resection. This is the exposure. They have to have a tracheostomy. They have a Dobhoff tube, which would later be converted to a gastrostomy. And as you can see, this is quite a large exposure. But once you get in there, it's still a very deep hole, and you don't have as much working room as you would expect from the illustrations. But this is the cosmetic result from it. So there is morbidity associated with these operations, and the number one problem is that there is, contamination from your normal oral flora. It doesn't matter how much you brush your teeth, how much you clean their mouth, they're still going to have bacteria in that region. And these patients that have severe cranial settling or basilar invagination have about a 20% chance of a CSF leak. So with this, the risk of meningitis is high, and if you have that, it can be a disaster for these people. And these people will have to be prolonged intubation, and the transmandibular ones will have a tracheostomy, and many of them need to have avoiding PO intake, and either with nasogastric tube or like these transmandibular approaches, they'll get a gastrostomy as well. They can have phonation changes, pharyngeal dehiscence, cosmetic issues, and probably one of the long-term worst problems is they can have a mandibular pseudoarthrosis. Kassam, back in 2005, I would call this pretty innovative as well. We weren't really thinking about this. Brought the endoscope into position. We were actually, I can think of actually one of the early cases that Alfredo and I did together back in 2005 when he just arrived on a Saturday. We did an endonasal transfenoidal pituitary tumor resection, which was something unheard of at Hopkins at the time, because at that time they were still doing our sublabial approaches, and I think we had to sneak this in on a Saturday so that our actual professors wouldn't attack us. They probably did attack us in M&M later, but anyway, so this is how Kassam approached this, and he would do the endonasal approach and take out the distal clivus to get the top of the odontoid. And this is innovative in itself. It's a different approach. I would think that the case he chose for this was probably not the right case, because he did have a pannus there, which would have been easily treated with just a C1, C2 fusion, but it accomplished the goal from what he was doing. But it still has some of the same problems as the others, and that you're still going through a contaminated field. And if you do get a CSF leak, it's still into the nasopharyngeal space. So it does have that same problem. From a cosmetic perspective, it's no better than the transoral approach. It's probably a deeper hole in the transoral approach, maybe a little bit easier to close. And I think that from a comfort level, most people now are much more happy to do this than a transoral approach, because they're so comfortable doing the endonasal approach from what we do for the regular other skull-based tumors. When I looked at this, kind of a odontoid sticking up into the head, and then it dawned on me one day. I was like, this is sort of, if we think about this like we do an odontoid screw, maybe we could do the same sort of trajectory, something different. It sounds a little bit wild, but what if we came from the neck and just went the same trajectory we do for an odontoid screw, but instead of putting a screw up there, we're drilling out the odontoid. So, this sort of started when I was a resident. We did a lot of odontoid screws because I was in a big trauma center as a resident, and as a resident at that time, we kind of had free reign, and there really weren't any attendings that ever showed up. So when we did these odontoid screws, we came up with different ideas and how we were going to fix these things. So the traditional odontoid screw had an Applebaum retractor, which is very much like a Cloward retractor with a third blade that goes underneath the pharynx. Looks great again in the illustrations, but in reality, this retractor never stayed in place and would flop around. It was sort of annoying. And so at the time, this is when these tubular retractors were coming into favor for spine operations. And we thought, what if we take one of these Metrix tubes, Metrix tubes, cut it at a bevel and use that as our retractor rather than using one of these Cloward type retractors or Applebaum retractors. And what it does is it actually allows the tubular retractor to sit up against the spine and gives you a 360-degree protection. So you're not going to injure the carotid once this is in position. You're not going to injure the esophagus by accident by having some instrument go errant. And it gives you just a great working channel, and you can see it on your fluoroscopy. And I thought, well, if we use this retractor to put in an odontoid screw, maybe we can use that same retractor to take out the odontoid. The same sort of case. So another beautiful illustration from Ian, and actually Ian won, I think, best illustrator in the world with this illustration, which is something that none of us will ever get in neurosurgery, of best of something in the world. It's such an incredible honor. But essentially what we're doing is we're taking that retractor and we're docking the top lip of that retractor on the anterior arch of C1, and the bottom lip is somewhere over C3, especially depending on how high the odontoid is riding in the skull. And then I thought, if you bring a drill in there, a diamond bit with some irrigation, suction, And an endoscope could actually work up in this area. So you could actually bring your view way up there. And in the beginning, particularly important, the other thing that came online was navigation got better. So if we could do intraoperative imaging with navigation, then we could really find out where we're going so we don't get lost in this whole area. And so I worked this out on cadavers in the lab. And then at the time, this was the kind of 3D imaging system that we had, isocentric C-arm, which gave kind of not so great images like this, but now imaging in the operating room is much better. This is what the endoscope setup looked like. And rather than looking down that hole with your head, you could look at it with endoscope. So your hands could be in a very comfortable position. And so you could look at the navigation and the endoscope at the same time. The anatomy, same anatomy as before, but all these structures like the carotids, they're all out of your way. So you're coming from the bottom of the odontoid and none of the stuff needs to be removed, and you're working behind the esophagus and pharynx in this area. So if you got a CSF leak, it wouldn't be a disaster. And this is the trajectory you'd be looking down, looking at from the bottom of C2 all the way up underneath the anterior arch. And the anterior arch actually is preserved in this procedure. So this is that same case. And this is after the odontoid resection. You can see it makes a funny shape to what's the remnant of C2 and 3, but the actual offender, the bone that's sticking into the brainstem, is removed. Another case just like that, you can see the removal and the decompression in this region. And even you can take out pannus up high, which really questionable whether or not you need to, but this was somebody who had progression, and also they had stenosis below, so you could do it all through that same regular anterior cervical approach. This was the early case series of 15 patients, and ranges in ages, and all the way from the older to the young 11-year-olds, and ranges in also the distribution of how high the odontoid was riding into the skull base, up to 3.5 centimeters. And like any operation, things have their complication. We did have spinal fluid leaks, which is not terribly surprising given the degree of basilar invagination. We had 3 of them, but none of them would get meningitis because it's a sterile field. We did have some dysphagia, but this was more related to trauma later rather than actually from the operation, but they're in our series as complications. We did have some instrumentation failures in actually a cranial nerve 12 palsy from an instrumentation. So that's not really related to the odontoidectomy, but related to the C1 screw placement. This is not really part of the innovative part of things, but I just wanted to illustrate how interesting our fluid dynamics are with spinal fluid. So this is a patient who had cranial settling, not the most remarkable cranial settling, but had a very large holosyrinx. And you would look at this and you'd say, well, it looks like there's CSF flow posterior to the spinal cord and brainstem and cerebellum going through there. And why would they get the syrinx? Well, she also had some brainstem symptoms from this. So the plan was to try to reduce this first. And if this was not reducible, then we would do an odontoidectomy to resect this. And this is we did this operation, but I also did this in the intraoperative MRI scanner because she happened to be very small and was able to fit in that scanner. And one of the interesting things about that scanner is that you're in a Mayfield, so if you get a scan pre and post, the patient's in the exact same position, so you can really measure changes. And so this is just the patient in the scanner. This is what the navigation looks like fused to pre-op CT scan, very beautiful colors and pictures, but this is what was the most interesting. So here, the top 2 pictures are actually the MRI scan intra-op before the odontoid resection. The second set of pictures in the bottom, left and right, are the intra-op MRI scans after the odontoidectomy and decompression of the brainstem. And what I'll focus on is what the syrinx looks like. And this blue and red line are the exact same spaces on the 2 different scans in the exact same position. And it looks like the syrinx is actually getting smaller immediately in the operating room without touching the syrinx at all. And this is the first time I've actually ever seen this, where you can actually document the syrinx is getting smaller. But I wasn't sure if this was real or not. And here's a follow-up image a year later. You can see that the syrinx is getting much smaller. And I have follow-up on her to 5 years where the syrinx disappears completely. But this, changes my thought process of how syrinxes evolve. Of course, this is not true for all syrinxes, but this is something to think about in fluid dynamics of the CSF. Now I'm going to change gears a little bit and drop down to the bottom of the spine. So the sacrum is an area of the spine that's very dear to me, and I perform a lot of sacrectomies, and also because of that, in this weird practice I have, I get a lot of other tumors referred to me, and most people don't think about schwannomas down in this region, but I see a lot of giant schwannomas in this area. And when we have to operate on these people, either they have a tumor that's growing, or it's so big that it's obstructing things, or they're getting neurologic symptoms from them. The traditional way of doing this would be going through the belly and doing a laparotomy or retroperitoneal midline approach to get here. And anybody who's worked in that area knows that, yes, this is a great big exposure, but once you get in there, this is a deep hole. And even with a headlight and your hands block everything, you barely see anything. It's hard to get an assistant to work down there. The colorectal surgeons know this, that it is just not a fun space to work in, because you just really can't see very well once you get your big hands in the way of things. Well, I had been watching a lot of surgeries from my friends, and I worked a lot with the urologists in the laboratory, because we had a robotics laboratory, and just, you know, I kept looking at this Da Vinci robot that they kept playing with. And I thought, oh, that's pretty cool. I wonder if there's any application that one day we could use in neurosurgery. And, you know, looking at a urology procedure, a prostatectomy, and they do it with the Da Vinci, I was like, you know, maybe we can do the same type of operation, but a little bit more closer to the spine to take out these tumors. So in order to do this, I thought, well, you know, how am I going to actually take this technology and bring it into neurosurgery, and how am I going to do this safe? More importantly, how am I going to do this safely, right? Because this is not something that we're trained in as residents. I mean, I remember general surgery, and I feel very comfortable with the different exposures in general surgery. And I remember learning laparoscopy, and I felt pretty comfortable with the idea of doing a cholecystectomy as a resident. But, you know, this is many, many years later, and whether or not you can do the same is a different question. So what I did was I decided that I would learn how to do Da Vinci robotic surgery. And I spent a year on the robot in the lab training with the actually urology residents and OB residents, just learning how to actually operate this device. And then I actually got certified on the Da Vinci by taking one of the Da Vinci courses. And in order to get certified, you had to do a live pig operation and perform a colectomy, I think it was hysterectomy, and cholecystectomy. And so, you know, not only did I have to learn how to use the Da Vinci, I had to learn how to do these operations again, because you forget these things very quickly after you leave surgical residency. So after doing all that, then I felt very comfortable on the Da Vinci, and I teamed up with the urologist for this operation. And let me show you what this looks like. So, you know, people are probably familiar with seeing the Da Vinci. It's a robot platform that's really based on 3D imaging. So it has a wonderful 3D camera for great imaging. It has no haptic feedback, and you sit at this console and move things. And what it can do is it mimics your hand or wrist movements by movements in the tips of these instruments. And so you can get into very small places as long as you have enough, as long as you have an open space to get into, and bring these instruments down close. And you can do very fine surgery with very large gross movements of your hand. And actually, where the Da Vinci initially was supposed to take off was in cardiac surgery, by able to, you know, visually stop the beating heart, but actually work on a beating heart and have the instrument move up and down as the heart beats, so that you could essentially perform what looked like a cardiac standstill bypass, but you're really doing it with the robot. In general surgery, the Da Vinci hasn't caught on as much. It really has caught on in urology and a little bit more now in OB. And I think the general surgeons are taking it more into account. I think it's a great thing, but you know, it is expensive. So, sorry. This is how the patient's positioned. So, you know, the patient was positioned in a lithotomy position, just like they would do for a prostatectomy. And then this big robot is positioned between the legs. And then there are different port spots for placing these ports. There's a camera port, and there's 3 robotic arms that can go in there. And then we actually have another arm that can be an assistant at the bedside that's generally working just like a regular laparoscopic assistant would be. And how these ports look, one through the camera is going through the belly button, and then you have these 3 different Da Vinci ports in green, and essentially how you have to triangulate things is you really want your center of focus of your operative field to be 20 centimeters deep to where your scope is, or so, down in the pelvis. If your belly button's your entry point, then the sacrum is, or the sacral prominence is about 20 centimeters from there deep in the pelvis. So that's sort of the perfect area. And then you want your ports about 8 centimeters away from each other. And this keeps the Da Vinci from colliding in with itself. This is what it looks like in a real person. And then these are the images that you'll see in the operating room. So this is looking from the belly button down, and you'll see it better later. But what I'm doing now is opening up the peritoneum over the sacral tumor and coming closer to the iliac bifurcation, and this is close to the sacral prominence. This tumor is coming off of S3. Now, if you did this in an open procedure, this is a deep, dark hole. But you can see that with the Da Vinci, you have this great movement. You can move and dissect carefully. You can see over there the uterus and the ovaries, and also you have these robotic arms that can work as retractors, so they can be your assistant. You can use monopolar, there's bipolar, and then there's a robotic suction tip that can both irrigate and suction at the same time, and I use it as a dissector. It'd be nice if it was like a Kittner, but it will work the same way. And you can dissect deep in that hole. So that's all the way where we're working now. It's all the way down close to where the sciatic notch would be, which in open surgery would be almost impossible to really see. You can get down there, but it's hard to really see what you're doing. And so you can dissect down this area, and this is working in front of the sacrum, bringing the tumor away from the sacrum, staying underneath the capsule of that tumor, and then carefully dissecting away. And then we can bring in a nerve stimulator, and this is one of the earlier cases where I actually brought a nerve stimulator in, but later I made some modifications to the Da Vinci instrument so you can actually stimulate with the graspers. And then you can stimulate down to see which nerves are pudendal and where things are and what is safely able to be cut and what needs to be dissected away. And it looks like there's some bleeding there, but this is actually fairly minimal bleeding. I think that the insufflation of the belly helps quite a bit to keep the bleeding down. And also you just have to be very meticulous in how you're dissecting, because big bleeding in this area could be a problem if you really can't control it. And then we can lift it up, put it in a bag, and then we bring it up to the belly button and then macerate the tumor in the bag and pull it out. So for these tumors, I've really only done this with benign tumors, because I think that a primary tumor like a chordoma would be dangerous with this, because you could spread it around in the belly, and I think that would be a horrible experience. One of the key points I was saying is that I think you really need to have meticulous hemostasis, because if the bleeding were to get out of control, I think you'd have to convert, and that would just change your operation. The benefit of this operation is that you have great 3D visualization. It's the best 3D visualization you can imagine. You can operate with bimanual dissection just like you would normally, and actually from a neurosurgeon's perspective, it's pretty second nature to operate like this, because we tend to use our suction in our left hand, if we're right-handed, to dissect with always, and we use a bipolar in our right hand or some other instrument to dissect with. So for us, using instruments to dissect seems pretty second nature. And you can use nerve stimulation in this region. You can have a second assistant if you need to. The downside is that there really aren't any bone cutting instruments for this Da Vinci. So it's really soft tissue tumors and benign tumors that we can use this with. And there are no haptics, meaning that you can't feel the tissue. You have to visually understand what you're doing so that you don't put too much stress on the tissue and cause injury. So I have made some modifications to this. And then how do these patients do? Well, they go right to the recovery room. There's no need for an ICU. The blood loss is minimal, less than 75 cc's, and then they went home on the second or third day post-operatively usually. And actually they could return to work at 1 to 2 weeks, which, after a big laparotomy would never happen in my hand. So this is a huge game changer as far as how people recover. From my perspective, the downside is we don't see that many of these types of tumors. So it's not that, it's not a big game changer for all of neurosurgery, but it is the beginning of something else, right? So how about bone cutting instruments? So I like to use these piezoelectric bone cutters for different things in spine, and I think they're great for skull based cases as well. But one of the things with robotics is if you're trying to use a drill to cut bone, you need a huge robot to hold that drill still in order to be able to cut bone, because the torque created by drill will really chatter and have things move. But these piezoelectric cutting devices like the bone scalpel or the sonopet type instrument, they don't work by rotations. They don't have that high torque. So this could be an instrument that could be converted into using with a Da Vinci type instrument. So in the lab, we made a version of this where we actually mounted a bone scalpel to one of the Da Vinci instruments. And we had a Da Vinci in the lab, so that made things a little bit more easy to use. And this is what the setup would look like. So that with the longer bone scalpel attachments, we could get actually down to the spine. And this is how the movements of this device look like. So you on a mock-up, so you can see how the Da Vinci can move in and out. And then inside, inside this box, we mounted a pig spine, and you can see the ability that we can have to cut the spine with the Da Vinci. Now, one of the things about this that is a little bit misleading is that, you know, it's not a wristed instrument, so you can only cut in one direction. This is a raw egg that we're cutting with the Da Vinci to try to actually peel the shell away from the membrane of the egg without breaking it and without having any of the egg white come out. And you can see that you can actually peel this egg and keep that membrane intact. So even something like that, you have the ability to do that. You don't have any tactile feedback, but you have the visualization to do it. So I think there are applications potentially in the future for this. This is still a crude instrument, and I don't think it's nearly at prime time. But as we innovate further, we'll maybe have something different. And other people might think of different ways to use this in the brain and other parts of the body, or maybe other types of robots altogether. So just in summary, what is innovation? Well, it's a new idea, a new method or device. What do you need? Not much. You really just need to look at things in front of you, change the angle of your view and thought process, change the application, and change what you're doing and seeing if it works. So with that, I'm going to finish up. And if anybody has questions, I'd love to field them. Hopefully won't shut down this thing by closing this here. So I'll stop sharing screen, I guess.
Yes, thank you, JP. This is beautiful. I already having a lot of comments here from the spine group. So I'm going to let them lead a discussion, some questions. A beautiful integration of spine, general surgery, the robot. Spine team, go ahead. Take it away, please.
Hi, JP. This is Selby Chen. I'm one of the spine faculty here. So great talk. I was actually curious, you know, how did you even start thinking about using the Da Vinci for these presacral tumors? And also, how did you go about getting trained in it? You said you spent some time with the urology team, is that right? So if you could just kind of talk about how you came up with the idea and then how you came about pursuing that.
Yeah, so one of the labs that I collaborated with, actually it's a robotics lab, and the leader of that lab, his name is Dan Stoyanovich. He's a PhD, and he actually develops robots, and we were working on actually a MRI compatible robot that could operate inside the MRI scanner on the brain. Even though I no longer do brain things, I still have a very big interest in that sort of thing. And he was one of the key scientists that made many of the parts within the Da Vinci robot. And so we would talk about the Da Vinci in different ways, just in how we could use some of these things for our robot designs. And because he was in the urology department, there were also a lot of urologists sometimes around. And so one of the urologists, Muhammad Alef, we would talk quite a bit, and we would also share cases together that were non-robotic type cases, just doing open tumor cases together. And then we would talk about these things in different ways. And I was curious to see what they were actually doing with this robot, because I had just heard about it, but I had never really seen it. And then I watched a couple of their cases, and I was like, you know, this is incredible, what kind of visualization they have and the movements of this thing. And you know, maybe it could be used for something in neurosurgery. And so, yeah, like you asked, then I decided that I had to train on this thing if I was going to use it. And when I was at Hopkins, they happened to have a robotics lab for training of their residents. And so they had a Da Vinci SI up there, and you could get on it at any time. And they had 2 different people that were dedicated just to training their residents on that. And so I asked them if I could come and learn. And so I just, when I had time, I'd go up there and spend an hour on this thing. I couldn't do it every day, and I couldn't do it every week, and I'd probably go crazy if I was doing that. But I was able to learn more and more. And then when I was talking to our hospital administrators about this and using it in neurosurgery, they all freaked out and they said, well, let me give you another hurdle to get through. So why don't you get certified to actually use this? So I went up to Temple in Philadelphia to take one of the Da Vinci training classes and get certified there, and did that. And then there was really, the next thing was to find the right patient that was willing to try this, understanding that we would potentially, in a strong potential of having this actually converted to an open operation, just like we had planned initially. So that's where it all started. And I always do these operations with a urologist or a urologist combined with a gynecological robotic surgeon, just so that I have somebody who's doing this on a regular basis, because these cases don't come up enough to get facile enough with placing these trocars and that sort of thing.
And JP, I'm going to go to Dr. McLaughlin right now to make some comments. I see her there at the American College of Surgeons meeting, and she's the chair of surgery as well, and an innovator. So I'm going to ask her some comments. But in the meantime, you talked about the chordomas. I think that's going to be the next frontier. I think devising inventing the ways to be able to, as you said, to be able not to spread the cancer, to contain it and stuff like that, because you and I know that those cases are still very invasive and very large. And I can tell that you're already thinking about this. So we'll go back to, there are some questions on the spine group, but Sarah, you want to make some comments? I see you there.
Morning. Thank you so much for a great talk. You know, representing the Department of Surgery and the general surgery piece, certainly we have seen some takeoff in the use of robotics, especially in bariatric surgery and some of the esophageal surgeries. And so really, I think as you talk about the ability to do those fine movements, and I think ergonomically, it's been a lot better from a surgical standpoint. I wonder, SP, I see you there, or Fernando, if you'd like to make a comment from a robot standpoint in general surgery.
Yeah, thank you so much. Q, is a great meeting, and thank you for inviting us. I think robotics are here to stay. There's no doubt that the technology, started with very, 20 years ago, and now is going through every specialty. And, when I joined Mayo 6 years ago, only colorectal was using the robot, and then we expanded for, bariatrics, redo operations, esophageal, hernias. So I think the future is that robots will be used in any single specialty because it makes things easier. It's just the interface between the patient and the surgeon, and it makes you a much better surgeon, much better operation. So now we call it Da Vinci. In the future will be a different robot, but the concept is that we are putting something in between the patient and the surgeon, and is the technology. So I think Mayo is extremely innovative in this. We have a group, the subcommittee, where we involve ENT, orthopedics, neurosurgery. So as you can see, it's going in every specialty. So I think it's the future is now, but more to come.
Perfect. Maybe I ask Dr. Thomas, who leads that committee of the robotics on the general surgery with Sarah and everybody here. Dr. Thomas, you want to make some, you saw, JP using that to take these tumors around the spine and stuff. So go ahead, Matthew.
Yeah, no, that was a great talk. Really enjoyed it. I think this is exactly where we're going to go with the robots in the future. I mean, not so future. I mean, even the present time. From the chest perspective, thoracic surgery, we have a number of cases here where we have done paraspinal schwannomas, intercostal nerve tumors, and even thoracic inlet, very difficult T1, T2 tumors, large ones. And we seem to be seeing a lot of these. And our go-to now is pretty much robotics, using robotics for these. So we have a series of these cases. I think within the last 6 or 7 months, we have done about 6 of these, and it's been great. So, traditionally doing large thoracotomies and all are out of the way. So, this is very exciting. Do you have any experience with endovascular robots or does anyone have any experience with endovascular robots for neurosurgery? Do you know anything about that? That would be great if you.
Yeah, so there is an endovascular robot that I'm blanking on the name right now, that was recently purchased by Siemens, that's now being sold by them. But it has, and our vascular neurosurgeons that are on the line probably will be able to correct me more, but I mean, it is incredible, that thing. And I'm not an endovascular surgeon, but I've played with that robot, and And it's like the spine robot, where it can take somebody who is incapable of placing a screw in the spine and make them capable of doing it without any knowledge. And this vascular robot, I mean, I could float a catheter anywhere with this thing, and I was amazed, right? Because I've never floated catheters besides central lines from when I was a resident. But you could float these catheters anywhere with very little training, which was surprising. They don't have them yet for neurosurgery applications because of the multiple channels that you need for that. But they are there, and I'm sure in the next 3 or 4 years it will be there. And then you'll be able to do something like, I would imagine you might be able to do something like telestroke stuff with the robot, and having these different satellite hospitals around where stroke, you have to be there so quickly, and you might not have that coverage at all these different hospitals, but maybe it's faster to set up one of these robots rather than fly somebody around. Or so I see the potential for that, but I'd love to hear from the vascular neurosurgery folks on that.
And Dr. Thomas, I saw, and I know you've been working with someone, they've been approaching you and trying to get in that space. I saw Dr. DeBiase is called Corindus GPS, apparently the company, but maybe Chris, you want to comment, Dr. Fox, precisely, because I know Dr. Thomas has been already thinking about this endovascular utilization of these robots.
And if I may comment, I think Ravi Talk also may have something to say about that.
Good. Go for it.
Yeah, I was just talking about the endovascular robot this weekend with one of my friends at the CNS meeting, who's actually in Chicago at Rush, and they just got the endovascular robot about a month ago. Certainly a huge amount of potential to do just what Dr. Wolinsky mentioned, being able to treat strokes at other institutions that may not necessarily have coverage. Obviously, right now there's the access issue, and I think the goal long term will be to have nurse practitioners or PAs who can get access to the vessel and then use the robot to move catheters. But right now, at least according to the few people I've talked to have used it, the technology is very early. It certainly has a huge amount of promise, but I think it's more difficult to do angiograms with the robot now than with human hands. But not unsurprisingly, I think, given the novelty of the technology, and certainly exciting things to come.
And Robbie, you're there as well, Dr. Todd?
Yes. So definitely, I mean, technology it's still early. I wouldn't say premature, but it's still on the early phase. And especially for stroke, it's a huge gain, as he says, basically, because time is the main issue. So maybe hub and spoke models, basically hospitals will put robots where they're covered, and all you need basically is some text to give you the access, connect the robot, catheters and micro catheters. So hopefully we'll see it at our site in the coming future.
Or even you can start the surgery, as JP said, at another hospital, or as the patient is en route to your hospital, the surgery can already begin in that device en route. I mean, it's just amazing the possibilities. I think JP mentioned installing the robot in another hospital, but imagine, and I know Dr. Thomas has been thinking about it. JP, this is the Department of Surgery has a big program, and is led, by Dr. Thomas right here as far as robotic multidisciplinary. So there's a lot of interest on this right here. I'm going to pivot now to Dr. Akinduro, because his head is waiting patiently with his hand raised. Go ahead, Olu.
Yeah, so Dr. Wolinsky, Olu Akinduro, I'm a 6-year neurosurgery resident here. Well, thank you so much for that.
I think you got muted, Olu, when you tried to switch. There
it is.
Go ahead.
Okay.
Yes.
Perfect. Well, I'll start over. So Dr. Wolinsky, thank you so much for that great talk. Olu Akinduro, I'm a 6-year neurosurgery resident here. I remember seeing some of the work you presented with the tubular retractor for odontoidectomy. I mean, watching some of that with awe, and now seeing some of this work you're doing with robotics for, sacral tumors. I mean, to me, that's hard to imagine. So my question is, how much resistance did you meet with the department and the people within the department to bring some of these new technologies in? And then as a pivot question, what advice would you have for young surgeons as far as finding ways to I guess, convince your department and your chair to allow you to use these things? I mean, are you having to bring some research to them? What are you doing to kind of convince them that this is something that you should be doing?
Well, so I think that, I think this is the same advice I'd give for somebody who's not actually trying to innovate these things too. So anybody who is finishing up their residency and going out into practice, whether or not it's private practice or an academic practice, is that you really want to hook up with or work in a place, an environment where you have a mentor there that can help you. And so when I came to Hopkins, when I started there, I worked with Zia Gokazlan, and we knew each other from when I was a resident at MD Anderson. And so he brought me up there, and we had a partnership right from the beginning. And one of the things that was wonderful about that experience is that if you have somebody who is already a full professor in that in a place that you're working with, and you're working closely with them, they kind of are protecting you to a certain degree, right? They're giving you some leeway to advance your skill, and they can bail you out in the operating room if you need it. But they're also giving you some protection in just the administrative side of things as well, because even when you're not innovating and you're just doing other operations, the complications happen, and these are the kind of nurturing things that you need to help bring your career along. And when you're doing these types of things where you're innovating and changing things, this is research, so you do want to make sure that you have full consent for these sort of things. But you also want to make sure that when you're doing them, you have everybody on board, that you're not just, making stuff up as you go, right? This is a planned, methodical technique that you're going to bring forward, and you're not going to just sort of willy-nilly bring it out, because then you're going to have disasters, and you won't really be able to convince anybody that it was a good idea at that point, and then you're done, right?
Yeah, exactly.
Beautiful. JP, I'm going to pivot now to Dr. Boriyama as the last question, if you guys don't mind, because I know that we're running out of time, and then I'm going to ask Dr. McLaughlin to give some closing remarks. But I'm getting tons of messages right here. Some of our surgeons have already working with Dr. Thomas and some of these robotic tumors, paraspinal, from the thorax to the abdomen and stuff like that. So Kingsley, are you there? You want to ask your question? He got disconnected, unfortunately. I think he just disappeared from my screen.
I'm right here. Can you hear me?
Okay. Yeah, I hear you now, Kingsley. Go ahead,
Okay,
please.
Dr. Wolinsky, a pleasure to see you again. Really a great talk, just phenomenal stuff that you're doing. My question is regarding the limited space for these, the cavity that's needed to use the vinci, and for most of the neurosurgical cases, it'd be limited. What is your thought on sort of a hybrid where, for the spaces that we need to expose normally, and then bring in a robot to do the fine motor work?
Yeah, so I think that, right, in most of the Da Vinci types of cases, you need some sort of working cavity. And they do now have a newer robot called a single port robot, which the ENT people are really exploring for doing transoral type of operations. They're different transorals than what we're thinking. They're working on taking tumors out of the pharynx and things like this. But you still need space. And I think you could do a hybrid type of thing with a robot like this, or maybe a different modification of a robot, where if you're thinking of doing a cranial case, maybe like what I would think would be a pretty interesting thing to do with it is to do like a bypass operation with them, because the magnification could assist you to just suturing with nano suture will feel like you're suturing with Ovicryl, right? But if you're actually not inside a body cavity, but you're using these instruments outside. Now, the technical difficulty with the Da Vinci is that it's designed with ports, right? And it knows where these ports are in spaces. And they use something called an RCM, or remote center of motion, where it's pivoting around these ports, just like the skin ports on your belly, right? And with that, it's trying not to put tension on those areas. So it's a different type of positioning than you would do if you're doing it outside the head than you would on the belly. So you'd have to really think about where those kind of imaginary ports would be. And you'd have to trick the robot into thinking that it's attached to a port. So what we found, and this is not knowing all the ins and outs of the Da Vinci, but when I was making that bone scalpel device, we actually had to make some ports for it, because if you can't use the Da Vinci without it actually docked to a port. And the ports have to be a specific size, otherwise the machine won't recognize that it's attached to a port. And so you have to trick it essentially to do it. But I think you could make a different type of robot, or a Da Vinci style robot that's more for open cranial procedures, right? And I think that would be a pretty awesome thing.
Beautiful. Thank you, JP. Dr. McLaughlin, you want to wrap it up? I know everybody's going to the OR and stuff like that, but we show the beautiful plaque that we have also for our speaker tonight. And I know Antonio is going to be representing you, but please, Dr. McLaughlin, wrap it up.
Dr. Wolinsky, thank you so much for joining us this morning. It was really a fantastic talk. I would say, if speaking for the entire Mayo Clinic of Florida, innovation really is becoming part of our DNA. And what really resonates is the idea that you can take something that you do every day and you look at it a little bit differently. And I think that's a really important thing for everyone to remember. And all of us can be innovators. So thank you so much. We really appreciate your time and enjoyed being with you this morning.
Thank you, JP. I know you have more meetings. Thank you, Sarah. Thank you, everybody. We are looking forward to the entire day, and we'll see you again, JP. And we're
thank you very much. Thanks for inviting me. Enjoyed my morning. It was wonderful. I think that what you guys are building down there is fantastic, and looking forward to seeing that carbon center. You're probably going to get a whole host of referrals from me once that thing's up, because now they don't have to go to Japan or Germany. They'll just come to Florida.
Yes, thank you, JP. I know you see some of those cases. We're excited. So good. All righty. Well, keep going with your meetings. Thanks, everybody. Have a great day. The rest of the day, tons of presentations. Bye-bye.